In the last section of our lecture, now we will talk about the carcinoma of the oral cavity. In this oral cavity, we will talk about the carcinoma of the oral tongue, then the hard palate, and also the cancer of the floor of the mouth. So, carcinoma of the oral tongue. On pre-existing leukoplakia, ulcer or syphilitic glossitis, usually the carcinoma of the oral tongue takes place if there is already pre-existing leukoplakia, white patches, ulcer or the syphilis which involves the tongue or syphilitic glossitis is present that can cause carcinoma of the oral tongue. Squamous cell type, the sites are the lateral border or ventral tongue aspects. So the common sites are the lateral side of the tongue or the ventral aspect of the tongue are the most common site for the involvement of the tongue. Here you can see the picture of the leukoplakia, white patches are present and there are the ulcerative lesions also. Spread of the carcinoma of the tongue, it infiltrates into lingual musculature. Lingua is the tongue and it involves the muscles of the tongue, spread deep or infiltrate the muscles. Metastasize to the lymph nodes, bilateral or contralateral. Both sides are involved or the lymph nodes of the opposite sides are involved in the spread. Submandibular and upper jugular lymph nodes are commonly affected. Submental and jugulo-omohyoid group is also involved. So the spread is through the infiltration into the deep structure and then through the spread of the to the lymph nodes, regional lymph nodes, which can be bilateral or contralateral. Submental, submandibular and the jugular lymph nodes are commonly affected. Clinical presentation, there is exophytic lesion like papilloma. That's the clinical presentation. It's the non-healing ulcer. They have rolled edges, shaggy base, and there is red induration. Submucous nodules, and the symptomatology of the cancer is there is early painless asymptomatic. So early in the staging it is asymptomatic, no symptoms are present, no pain is present in the early stage. Then as the ulcer forms and there is infiltration of the tumor, then there is pain in the tongue is present. Pain in ipsilateral, same side. If this side of the tongue is involved, then on the side of that side of the ear there is pain also. Lump in mouth. Enlarged lymph nodes are present in the neck, dysphagia, bleeding, and there is slurring of the speech present. So all these are the symptoms because the tongue is involved. There is pain in the mouth, there is mass in the mouth, and there are involvement of the lymph nodes, enlarged lymph node, difficulty in swallowing, dysphagia is present. Tongue plays an important role in swallowing, making up of the bolus combined with the saliva. So all that is affected, and there is slurring of the speech also because again movement of the tongue is very important for making up of the speech. So all these are affected and the common symptoms are there. Treatment is small tumors, the radiotherapy or surgery is performed. In stage 2, radiotherapy, surgical excision with neck dissection is done. And in stage 3 or 4, then we have surgery and post-operative radiotherapy. So surgery and radiotherapy are the main treatment options. So far, what we went over the cancers of the oral cavity chemotherapy, the surgery, and the post-operative radiotherapy are the treatments for the cancers of the oral cavity. Haemangioma, half of the tongue is removed if it's on one side and it's affected. Block dissection, neck is always done. Carcinoma of the hard palate now is squamous cell or glandular variety. Squamous cell is the most common for the tongue also, and then for the hard palate it's the common type. From minor salivary glands, adenoid, cystic, mucoepidermoid, or adenocarcinoma. These are all the different types of cancers that can affect the hard palate. So we have squamous type, glandular types, adenoid, cystic, mucoepider. These are the different types of the tumors of the soft hard palate. Superficial ulcer occurs and there is ulceration, and the spread of the tumor is through the lymphatic metastasis. Spread to gingiva, lip, soft palate, and bones. Treatment is small tumors are resected, larger are there is partial maxillectomy, block dissection, and there is closure by suitable prosthesis. So treatment is again by the surgery and prosthesis, and the small tumors are resected. Carcinoma of alveolar ridges, also called gingival carcinoma. So carcinoma of alveolar ridges is the gingival carcinoma. Gingivae are the gums. Site involved is lower jaw behind the first molar. Spread to cheek, retromolar trigone and hard palate. Invasion of bone. Spread to neurovascular bundle, nodal metastasis, and submandibular and upper jugular nodes are mostly involved. So it's the tumor of the gums, mostly the back side, lower first behind the first molar is the site that is involved, and then we have it spreads to the different portions, and the spread is mainly through the lymph node metastasis, and the jugular and the submandibular lymph nodes are commonly involved. Treatment of the carcinoma of the gums is surgery. Wide excision is done. Local excision with mandibular marginal resection. So we said that the common site is the lower behind first molar. So the mandibular resection is required if there is bony extension and involvement. Segmental or hemimandibulectomy, half of the mandible is removed. Block's dissection can be combined with the hemimandibulectomy. Partial maxillectomy if the lesions are upper area or upper gums or gingival ridges are involved, then we should be or upper alveolar ridges are involved, then we should do the maxillectomy, partial removal of the maxilla. Cancer of the floor of the mouth. Males are affected more. The ratio is big difference, 4:1. So 4 males, 1 female is affected. Lesions usually occur near the opening of submandibular duct. This is the floor of the mouth, submandibular. Enlargement of submandibular glands occur. Ulcerative or infiltrative type. So ulcers may be formed or there may be infiltrative, they penetrate deep. Metastasis to submandibular lymph nodes occur. Treatment is surgical excision, radiotherapy, wide excision, marginal or segmental mandibular resection is performed. So as far as the cancers of the oral cavity are concerned, we notice the treatment options are surgical resection, surgical excision, and radiotherapy are the two main treatment options, not the chemotherapy as one of the most prime treatment options. And block dissection is also done. Carcinoma of retromolar trigone. Involvement of retromolar trigone. Retro is behind the molar. There is a trigone. Primary or secondary to extension from gingiva, floor of mouth, or mucosa. So involvement of the retromolar trigone can be as a primary involvement. The cancer appear from the retromolar trigone, or it can spread from the gums, floor of the mouth, or mucosa. Treatment is depend on the extent of the lesion. Wide surgical excision, block dissection are the treatment for the carcinoma of the retromolar trigone. So this was all about our lecture, Cancers of the Oral Cavity, in which we talked in detail about the benign tumors, premalignant lesions, and then different cancers of the oral cavity, lips, hard palate, tongue, floor of the mouth, and then the gums or gingivae. So hopefully you learned about this topic after this lecture. Thank you for watching sqadia.com.